So good evening, everybody. I'm going to present three cases today. All three cases are very common. So we are basically focusing on these cases, like what are the mistakes in management that we tend to do. Like I'm not pointing the mistake to other people, but we sometimes tend to do mistakes during management. And basically we'll be discussing whatever were the mistakes done and what could be the correct line of management in all three cases. Okay, the first case is lumbar disc prolapse with radicular pain in the leg. Second is very common, that is headache and migraine. And third one is I'm discussing regarding a knee pain. So all three cases are very much common in day-to-day practice. So commonest causes of mistakes by medical person or any other person are these listed that I have provided. One is sometimes there can be mistakes during prescription of medication either by us or by the pharmacist. So sometimes we can mistakenly write the name of other drugs, or the pharmacist who is delivering the drug can give the another drug whose name is almost similar to the prescribed drug. So that can be one of the mistakes. Another is misdiagnosis or failure to diagnose. This is one of the most common mistakes that we do during management of the patient. Sometimes, for example, if the patient comes with the back pain with radiating pain in the leg, and yeah, and if the MRI shows disc prolapse of L4, L5 or L5S1, so we tend to jump into the conclusion that this leg pain and back pain is due to the PIVD. But actually, in close examination, the he or she might have some SI joint pain or facet joint pain. That pain may be radiating, or piriformis syndrome, which may be radiating to the leg. And sometimes we tend to do disc surgery instead of just giving like infiltration of piriformis or SI joint injection. So that is one of the commonest mistakes that we can do during management. Another is insufficient medical training or skill. That is one of the cause of the common mistakes that we do during management. What happens is after finishing our like career, suppose if I do like fellowship in pain medicine, generally what we do is we don't tend to upgrade ourselves. And medical science is such a subject that every once in a while there will be upgradation of various like guidelines by various countries. So if we are not updated, and we tend to follow the previous guidelines, or we tend to go for the experience based treatment rather than evidence based treatment. So that can be one of the mistakes. And what I'll be talking about all three cases is basically these type of mistakes. That is, we tend to rely more on experience based treatment rather than evidence based treatment. So that can be a commonest mistakes that we do regularly. Another is insufficient medical facilities. Suppose you are upgraded, you know everything, but what happens is you are posted in some places or remote places, or even in the city where you don't have that facility. For example, if the patient will have a very good relief with radio frequency ablation of the nerve, but you don't have any facility of radio frequency machine, so that can be sometimes lead to mistakes in management of the patient, which is also very much common. Failure to treat is another mistakes that we do commonly. And finally, financial issues are now growing very much. So sometimes we tend to be more, I don't want to say some negative things, but sometimes we doctor, sometimes we forget that we are doctor, and sometimes we think that we are businessman. And sometimes what happens is the procedure that gives us more income, we tend to focus on that, and the procedure that is giving less income, we tend to neglect that, or we don't try to do that. So that can be one of the mistakes. For example, if a patient with disc prolapse, lumbar disc prolapse come to you, and you know that a simple transforaminal epidural steroid injection will do wonder, but you tend to focus on surgery, like even endoscopic disc surgery, because like the amount of money that you will be getting following surgery will be much more higher than transforaminal injection. So that financial aspects can sometimes drive the physician to do some things that are not under the guidelines, or if they are under the guidelines, they tend to over under they tend to go to the procedure that will yield or give more financial benefits. So these are few common mistakes that we tend to do during our clinical practice. Okay. So first case I'm presenting is basically a case done by me like 3 years back. It was an ozone disc on nucleolysis for treatment of recurrent posterior intervertebral disc prolapse. Okay, so if you go to the case description, it was around 2020. And actually, the case that I am presenting right now is one of the student who is also studying pain medicine. I don't want to reveal her name, but she is an anesthesiologist, and we met 3 years back with back pain. And currently, because our back pain was so much like with the ozone nucleolysis, she was completely fine till now. So that was one of the motivation of her to become a pain physician. So she's also studying in maybe she's not in the class today, but she's under 15th this basic course of pain management. Okay, so a 34 years female patient with average build, who is an anesthesiologist by profession, came to me 3 years back with complaint of low back pain and left leg pain. And if you ask the history, back pain was for 6 week duration. Her visual analog score was 7 by 10. Maximum pain in the back was 7 by 10. It was left-sided pain, and it was sharp, deep aching, and occasionally radiating to the thigh. And it was aggravated on sitting, standing, or sitting to standing, or even during walking. And the pain was relieved on lying supine and while doing a massage in the back. Okay, so if you see the leg pain history, leg pain started 1 month back, that is 4 weeks back, and it was constant burning, tingling, and it also radiated from the buttock to the calf and occasionally to the ankle, and it was aggravated by any movement and only relief with massage. And on examination, on asking, like bowel and bladder habit was normal. So in if you see the past history, she had undergone lumbar discectomy under general anesthesia in 2015 as well as in 2018. So she was operated 2 times for symptomatic disc prolapse at the level of L3-4 and L4-5. And at both time before surgery, so they waited for 1 to 1.5 months. In this time, she basically went for conservative management and was advised to go for physiotherapy. And once the physiotherapy did not yield good result, she was advised to go directly to the surgery. And she was not advised to go. She was not given any option of other non-surgical option. Okay, so that is one of the mistakes that we tend to do after waiting certain time. Normally the orthopedician as well as the neurosurgeon, they would not go give the opinion for the transforaminal or ozone nucleolysis. A simple percutaneous injection can have a beautiful result, but instead of that, they would tend to go directly to the surgery. I'm sure because she was a doctor and anesthesiologist, they waited for 1 to 1.5 months. Otherwise, the normal trend in this part of the world where I'm staying is after diagnosing PIVD, they usually tell the patient to go for operation as soon as possible. Otherwise, they tell that they will go for they will the leg will not move. They will be paralyzed if you don't take care. So these kind of things. Negative motivation are usually given to the patient, and patient is usually basically they are pushed to go to the surgical intervention, and they are not given any other option in between surgery and between the surgery or the conservative management. Okay, so that is one of the common mistakes that we do during management. And in 2015, the first episode of back pain and leg pain was usually while started when she was shifting the patient from one bed to another. This led to her back pain and radiating leg pain in the leg. And in second episode, that was around 2018, pain started while lifting her luggage in the airport. So that was a trigger for her previous two PIVDs. And each time after surgery, she was hospitalized for 1 week. Okay, so on history, there was no history of any allergy to any food or drug. And this time, when I met, when she came to me in 2020, she was under non-steroidal anti-inflammatory drug, which basically relieved her back pain. But only tramadol could relieve her back pain. Other non-steroidal anti-inflammatory drug was not helping her at all. She was under muscle relaxant baclofen and pregabalin. So that was the current medicine when she was visiting me. And on physical examination, she was average built. She had an antalgic gait with normal vital sign. The pain detect tool was score was 18. That means the more pain was in neuropathic in nature. Our PHQ score was 6. Normally, PHQ score is usually done in most of the patient with chronic pain to see the mental status of the patient. Like sometimes PSQ score can be high, which basically points to the diagnosis of some kind of depression, either it's mild, moderate, or severe. And on systemic examination, mainly back examination, her range of motion, both flexion and extension was painful. On palpation, there was tenderness in left lower paramedian area in the back. On examination of motor, her this left dorsiflexion of left foot was slightly weak, and the grading was 4/5. That is basically if dorsiflexion of the left of the foot is basically is done by L4 nerve root. So her L4 motor power was 4/5, slightly decreased. She also had sensory loss of about 10% at around the area of L4 dermatome of left leg. Her reflexes was intact. On straight leg rising test, it was positive at 45 degree, and favor and fear was both negative. So on, and she had an X-ray done. It showed mild lumbar lordosis, loss of lumbar lordosis. Her blood reports were all normal, and her MRI showed history of lumbar discectomy at L34 as well as L45. And basically, it also showed recurrent left paramedian disc protrusion with slight caudal migration of the L34 disc, which was compressing her left L4 nerve root. And the MRI also showed L45 mild lateral recess stenosis with bilateral L45. Um, uh, and left-sided L34 neural foramen stenosis. So that was her MRI picture. So this was her MRI picture. You could see at the level of L4, L5, the disc is desiccated and it is protruding, and it is impinging the anterior thecal sac. Similarly, in L4, 5 also, there's a disc desiccation and small disc protrusion, and you could see the evidence of previous surgery in her MRI also. So this is a sagittal picture. If you see the axial picture, at the level of L34, you can see a used paramedian disc protruding and compressing the traversing L4 nerve root. So this is the axial picture of the patient, of the same patient. So regarding the diagnosis at the time of examination was recurrent posterior intervertebral disc prolapse at L34 and left L4 with left L4 radiculopathy, and she was also having left L4 L5 facet joint arthropathy, and she was managed with intradiscal ozone nucleolysis with transforaminal epidural steroid injection at the level of L34 left side, and she was also given intra-articular steroid injection in left L4, L5 facet joint. So this was the management. Okay. So this is some of the picture that I took during the offer. So you can see here the facet joint injection being done in left L4, L5. So this is the needle. You can see the needle here in the facet joint. So, and 10 milligram of methylprednisolone was given, and this is the picture of the ozone nucleolysis where you can see a long needle going into the intervertebral disc. This is the lateral image, and this is the AP image. In both images, you can see the needle going into the disc. So, okay, so here normal 6 ml of intradiscal ozone of concentration 35 mics per ml was injected, and again 10 ml of periforaminal ozone was injected, and at the same site 10 ml of 0.25% lignocaine and 40 milligram of methylprednisolone was given in the transforaminal region. So that was the management given to the patient at that time. So, and with the result, back pain subsided immediately. So, if you see the leg pain on same day, it subsided by 50%. Second day, the pain score was even less. It was 4 by 10. In third day, pain score was 2 by 10. And on fourth day onwards, she was completely free. And she was given pregabalin 75 milligram at night for a 1 month, and follow-up was advised after 1 month. Okay. So, this was the picture of the patient. So I don't think. Okay, so this is another picture of the same. I'll come to this picture later on. Basically, if you see the conclusion, what I meant by the mistakes in management, first you always have to know that people with disc prolapse usually suffer a lot, and this suffering is usually like they tend to do whatever is told to them. Okay, normally when you go to the surgeon, they usually advise to go to surgery immediately. They don't wait for any, they don't give time to the patient, and they don't counsel the patient that this disc prolapse usually will heal by itself in 80% of case. As we commonly do in Daradia pain clinic, we always follow these guidelines. Normally when there is disc prolapse, usually 80% of the time disc prolapse will heal by itself. If okay, so we can wait for, normally we can wait for 4 to 6 weeks, and in this 4 to 6 week we usually give body to chance, give body the chance to heal by itself. Normally in 80% it will heal by itself, and within this 4 to 6 week period, patient usually go to the physiotherapy for more like for relieving the pain and the symptom during that time. So if there is no red flag, so I want to focus again. If there is no red flag in any patient with PIVD, red flag also includes like severe pain is also included as a red flag. But if there is no severe pain, or if there is no red flag, then we can very normally we can wait for 4 to 6 weeks. Okay, and 80% body will heal by itself. If by 4 to 6 weeks, if the disc prolapse is still giving the patient the problem, then, and if there is no red flag, then minimally invasive procedures should be tried before we advise the patient to go for surgery. In this case, the main thing that I wanted to focus was here, the patient is also a doctor. She was not given any non-invasive procedure options. She was directly told to go for surgery in both time. In 2015 also, it's same thing happened, and in 2018 also, she was not given any option of epidural steroid injection or even ozone nucleolysis. Okay, so but this time in 2020, she heard that one of the pain physician is there who is not doing any surgical management. He usually cures by giving transforaminal and ozone injection. And she came to me hoping that non-surgical intervention will cure her, because she had already gone for surgery 2 times. So, and after the ozone nucleolysis till now, she is completely pain-free. In 2021, she came with back pain to me, but on careful examination, it was a facet joint which was causing her problem. And in 2021, in same patient, just facet joint injection was given in left L34 and L45. So till today, like 2023, she's completely fine. And this was one of the motivation for her to go to pursue pain as her future, and she was motivated to become a pain physician after this case. Okay, so this is commonly done mistake. I'm sure in your places also, the neurologist or the orthopedician would not go for any non-surgical intervention, but they usually go directly for the surgical intervention. But evidence suggests that simple percutaneous ozone nucleolysis or even transforaminal epidural can have a wonderful result in back pain. And especially ozone nucleolysis can be done both in contained as well as in non-contained disc herniation. And transforaminal epidural steroid has much more effect if the disc is contained. And if the disc is extruded, then transforaminal epidural steroid can have some, may not have that much efficacy regarding the outcome. But if the disc is contained, then usually you should always go for, or advise the patient to go for transforaminal epidural steroid. Or even if your pain clinic has ozone nucleolysis facility, and if there is no red flag, then we would advise you to go for these non minimally invasive procedure before giving any advice for a surgery. Okay, so this is one of the case. I want to in same case, I want to link one another case which was seen by me a few days back. So here also a 71 years old male came to the clinic with low back pain and leg pain for 1 year, and he was diagnosed with disc prolapse at the level of L4, L5, and surgery was done 7 months before. But even after the surgery, he had um, no improvement regarding pain. And on examination, he had a surgical scar mark, and both favor and fear was positive, and his straight leg rising test was positive at 40 degree. Motor, sensory, and reflexes were all normal. So in these cases, what we do, because this is a chronic case, in these cases, pulse radio frequency of dorsal root ganglia has a very good result. So if normally ozone and transforaminal epidural steroid injection is very good in subacute subacute cases. But if the lumbar disc prolapse and radiculopathy is chronic, so that means 1 or 2 or 3 years, yeah, if the patient is living with the radicular pain for more than 1 year, then in these condition, you can always go for pulse radio frequency of dorsal root ganglia. And same thing was offered to the patient, because previous surgery was not yielding or any benefit. We went for ozone nucleolysis and pulse radio frequency of DRJ. So after doing these two procedures, patient had an excellent result. So he came to follow up after 3 months after the 2 months after the procedure, and he was very much happy that although he underwent surgery for disc prolapse 7 months back, which did not help him at all, this ozone nucleolysis and pulse DRJ at the same level was gave him an excellent result, and he was very happy about that. So I wanted to include this case also. Um, so normally in disc prolapse, normally we wait for 4 to 6 weeks. Once the acute or subacute phase subsides or goes, and if the patient is still having pain, then in these cases ozone nucleolysis and transforaminal epidural has an excellent result. But if the same case, if the patient comes to you 2 3 years after the disc prolapse and with the radiculopathy pain, then in these cases pulse radio frequency of the dorsal root ganglia of the nerve which is causing radicular pain has an excellent result. So these two cases basically is a thing. These two cases you have to see that in both cases we manage the patient without any surgical treatment with minimally invasive for in first case transforaminal epidural with ozone nucleolysis, and in second chronic case we managed with ozone nucleolysis with pulse radio frequency ablation. Okay, so this was one of the case. Okay, so another case I would want to discuss is regarding the headache and the treatment with headache. So I'm presenting a case of occipital nerve block for treatment of intractable headache, which was treated as migraine. So this is also very much common. Patient with headache and migraine will come to your clinic, and you have to know the normal evidence-based treatment in these cases. Okay, so the case description is as follows. Here also a 34 years old male came with average build. He was a software engineer. Came with he was working in the United Kingdom. Okay, he came to the pain clinic with history of headache for 1 year. If you if you ask the history, the headache was sudden on onset, in left-sided 1 year back, and it was deep aching and throbbing in nature. His numerical rating score was 5 to 8. That means moderate to severe pain he was having, and that pain was radiating from back of the neck to the left side of the temple. Okay, so that is the one of the catch point. Radiation of pain from back of the neck to the left side of the temple was the main complaint, and it was aggravated by increase in workload or if there was any food disbalance. And he did not tell me any other triggering factors, and it was relieved partially by acetaminophen, that is paracetamol and ibuprofen. And and there was no history of migraine in his family. Duration of pain was usually 24 to 48 hours, and frequency, he was having everyday pain, and he was taking this paracetamol and ibuprofen for last 3 4 months every day. And he was having occasional nausea, and he was having occasional photophobia as well as phonophobia, and there was no aura in the patient. Okay, in if you see the past history of the patient, he was hypertensive for last 3 years, and he was under losartan 50 mg OD. And with this problem, he visited multiple. With this headache problem, he visited multiple doctors in UK, and there they could not cure his headache. So he came back to Nepal with the same problem, hoping that he will. So because in United Kingdom, the problem he was facing was he was first initially seen by GP, and he was not referred to any other or doctors. So he was frustrated by this. So he came to Nepal for further management of his problem. And in Nepal, he was diagnosed as migraine, and he was under multiple medications. So he was currently under amitriptyline 10 mg, he was under escitalopram, clonazepam, sertraline, alprazolam. He was also having naproxen, ibuprofen. He was also taking rizatriptan 10 mg SOS, and he was also under proton pump inhibitor. So he was under almost 7 different drugs when he visited the pain clinic. And even with these 7 different drugs, he was not having complete pain relief. He was only having partial pain relief. Okay, and he also had with this problem, when he was showing to various doctors in Nepal, incidentally he had a left molar tooth extraction, thinking that that was the source of pain, and he extracted his left molar tooth, thinking that that will cure his headache. And incidentally, at the same time, he had cholelithiasis also. So he underwent laparoscopic cholecystectomy also, thinking that that was the source of pain, and it would cure his headache. So whatever doctor told, he was doing everything. Somebody told that it was due to dental problem, he extracted that tooth. Somebody told him that it may be due to the cholelithiasis, and sometimes that can happen. So it was basically any non-medical advice was given to him, and he also went for laparoscopic cholecystectomy within this 2 years period, 1 year period of headache. Okay, on examination of general examination, his higher mental function was intact. Cranial nerve examination was normal. On examination of the neck, his range of motion of the neck was normal. He was having tenderness in left greater occipital area and in left lower cervical facets. Tinel signs was positive. That means when we press the greater occipital nerve area, he was having similar type of radiating pain that radiated from the neck to the occipital area. And he also had a CT scan of head with him, which showed hypoplastic bilateral frontal sinus. So here the catch point is, when doing a physical examination or general examination, for diagnosis and for management, we have to give much more time for history and clinical examination. If we don't give time for history and clinical examination, few things can be missed. For example, in this patient, he was clearly having occipital neuralgia along with migraine. He might have migraine, but this pain that is bothering him right now for the last 1 year was because of the occipital neuralgia. Okay, and history also was suggestive. He was having radiating pain, which started from the back and it was basically radiating up to the left occipital area. On examination also, it is very much clear cut that if you are basically compressing the greater occipital nerve, he was having similar type of radiating pain. Okay, so and I told him that it can be due to the greater occipital neuralgia. And on the same day, we did ultrasound guided left greater occipital nerve block at the level of C2 with 4 ml of 4 ml of drug, 1% lignocaine, and 20 milligram of methylprednisolone. Uh, his pre-procedure pain score was 10 by 7 by 10. 1 hour post-procedure, the pain score decreased to 2 by 10. And on follow-up after 3 days, pain subsided to 1 by 10. So so if you can see with a simple injection in the greater occipital nerve area with hydrodilation and application of steroid in that area, he is completely pain free right now till now. Okay, so so this is like so this is one of the this is the picture. I don't know whether I can play. I'll be showing you the video of the procedure. So this is the procedure that I did. I don't know whether the video will be. I will be playing you the video after this course is after this presentation is over. But here you can see this is the lamina of the C2, and this is the inferior obliquus muscle. This is splenius capitis, and you can see splenius capitis. You can see needle coming here. So this is lower one is lamina. So we injected in this part where is the location of the greater occipital nerve, and after injection he is completely pain free till now. So if you see the indication of greater occipital nerve block, this greater occipital nerve block is one of the excellent technique, especially if the patient comes with headache, with long-term headache, and if we want to break the pain cycle. Even if there is no greater occipital neuralgia, then sometimes the greater occipital nerve block can have a wonderful effect on terminating the headache or even migraine. So I have listed the various indication of greater occipital nerve block. If you see the indication, it is given in most of the cases of headache. You look, migraine in migraine with aura, migraine without aura, or chronic migraine also. In these cases also, this is one of the indication of greater occipital nerve block. Sometimes in tension type headache, both in episodic and chronic, in cluster headaches also, in chronic daily headache, or even.
Series, you can make it a full screen. You are not playing with the full screen mode.
Okay, sorry, sir. So if you see the indication of greater occipital nerve block, it is not only given in greater occipital neuralgia. Here, the indication for greater occipital neuralgia is at the number of 10. Robert, it is, if you see, you can give this greater occipital nerve block even in various type of migraine, tension type headache, cluster headache. So these occipital nerve block in these conditions usually helps to break the pain cycle. And sometimes if the patient is in chronic medication, sometimes the medication itself can cause headache. So medicine induced headache. In this condition, we can give greater occipital nerve block for a certain period of time that will take care of pain, and later on they can also continue the the drugs that are they are having for migraine. But that time, small amount of drug will take care of the headache. So here I want to focus that greater occipital nerve block is not only given in greater occipital neuralgia, it can be given for various other condition of the headache very commonly. And if you see the indication here, they have listed post-dural puncture headache also. In those cases also, they are giving a greater occipital nerve block to take care of pain. So, yeah, and even in trigeminal neuralgia, if the trigeminocervical complex is, if it's affected, then here also greater occipital nerve block has a excellent relief. The video, I'll be showing you the video at the end of the class. So this here the the conclusion of this case is that whenever patient with headache with migraine comes, and if the normal medication is not helping the patient, then we have to basically broaden our diagnosis. It is not that only migraine will cause headache. Sometimes the patient can have migraine, isolated migraine, but sometimes a patient can have migraine with other cervicogenic cause of headache also. Sometimes they can have facetogenic headache, or they can, in these cases, like you can see in these cases, yes, he was diagnosed with migraine with he was taking lots of drug for migraine, but the occipital neuralgia that was aggravating his headache was completely ignored. And I'm sure none of the physician did any clinical examination. They did not palpated his back, head, and occipital area. If they have palpated any of this area, then they could clearly identify that it was due to the greater occipital neuralgia that is aggravating his headache currently. So sometimes when the patient comes with migraine and if it's not helping, then broaden your diagnosis. Okay, always think that my all every time migraine is not only the culprit that can cause headache. Sometimes migraine can be associated with tension type headache, or it can be associated with like cervicogenic headache. And if you address this tension type headache or cervicogenic headache, then it can have a wonderful effect in the patient. And second thing, most commonly, another thing is always rely on history and clinical examination and stick to the basic. For example, in this case, he was typically saying that the pain was radiating from back of the head or occipital area or neck area towards the occipital to the temple. So that generally happens in greater occipital neuralgia. And on palpation also, he was having tenderness in greater occipital region, and the pain was reproducing. The palpation of greater occipital nerve was reproducing similar kind of pain that he was having. So this history and clinical examination suggests that it was greater occipital neuralgia. And with this injection only, he is completely pain free. And also remember, you have to know when to do the intervention. Okay, so normally he was having seven different type of drug, like sedative. He was having SNRIs, he was having SSRI, he was having NSAID and other various drug. But if the patient is psychologically disturbed and he is on multiple medication, then you should think of some intervention that might help. So WHO also has given us the WHO pattern of this pain treatment. Initially, it was for cancer pain management, and at that, if you see the ladder, WHO pattern ladder, normally what happens is after if the pain is not relieving with like opioid or strong opioid, then we go for intervention. But in 2018, what happened was the American College of this intervention physician, they basically changed this pattern, lather pattern. What they did was, after if the pain is not addressed with moderate, if it's not managed with NSAID or mild opioid, they would go for intervention before giving a strong opioid. So this was basically to prevent the overuse or misuse of opioid. But same thing can be applied here. Okay, if the patient is having multiple medication and it is not relieving, instead of adding on other multiple medication, or instead of like just neglecting the pain, you can go for some intervention. For example, here we did greater occipital block. You can try for sphenopalatine block, or you can go for other blocks in the headache that is commonly used. So I just wanted to tell you that any headache, just think of other causes of headache, and it can be mixed with the previous condition. And sometimes we tend to think that only migraine is not getting better, and we tend to add more and more drug to the patient, which happened in this case. Instead of thinking out of the box and thinking that there might be another causes of headache. And second is always rely on clinical examination and history, and stick to the basic. So that will guide you for a proper management of the patient. And third is know when to do intervention. And in these cases, sometimes simple intervention can change life of the patient, and give him a good pain relief. Okay, so this was another case. So this was the of the this was the case history of the patient. So as you can see, the red box here, that was under there was tenderness in left occipital area and lower facet. So this was just the history, and this is the procedure that we did. And he was given just simple analgesic for 3 days to take care of the needle injury. And after follow-up, After 3 days, 72 hours follow-up, he was completely pain-free. So this is the real case that I was presenting. And third case is basically of knee pain. Okay, so knee pain, as we all know, it is one of the most common cases that we see in OPD, and we also see that this knee patient with knee pain or osteoarthritis knee is most commonly mismanaged. Okay, we basically manage knee osteoarthritis very casually in my part of the world. I don't know whether it's nicely managed in other part of the world, but where in my part of the world, this knee pain is commonly mismanaged. So I just want to present the case which was mismanaged by other orthopedician. Okay, so here a 62 years old male, heavy built male, his weight was about 92 kg, came with knee pain for 6 years and leg pain for 3 years. On his present illness was this knee pain was sudden in onset. On onset, only right-sided knee pain was there since last 6 years, and this pain was basically aggravated while climbing up and down stairs and while walking. And this knee pain started while he was driving, while he was going for a long drive, and since then he was having continuous pain. And he also says that pain was relieved on rest, and he also complained of bilateral calf pain. And he was taking in his medical history, he was given intra-articular steroid injection 2 years back, and both time he had a 6 month pain relief. And he was saying that occasionally he has a high uric acid level. So here the catch point is, whenever so same similar problem will similar cases will come to you for come to most of the pain physician. Usually patient comes with knee pain, and if you go in detail, ask in detail, they usually will have intra-articular steroid injection 2 or 3 or even 5 times before visiting your clinic. So here the main problem is, here previously intra-articular steroid injection was in the guidelines. Okay, but nowadays if you see the current guidelines, we never give intra-articular steroid injection in primary or even sometimes in secondary osteoarthritis knee. In my part of the world, there is a common practice is that whenever a patient has a knee pain, they usually go for a steroid injection. These patients are not given any other like advices to go for prolotherapy or other therapies. Okay, but nowadays in osteoarthritis knee, normally we go for the prolotherapy instead of going to the intra-articular injection. And it is said that one of the intra-articular injection usually pain relief is immediate, but long-term benefit is not there. It will further cause destruction of cartilage, and pain relief will be for 3 to 6 months normally. After 6 months, like in this case, again pain will reappear. And not knowingly, the physician are basically mismanaging this case by injecting steroid every time they go to the doctor. Okay, so on examination in this patient, he's of the back, because he was complaining of leg pain also. Range of motion was normal. There was no tenderness in back. Favor, fair, and SLR were all negative. Motor, sensory, and reflexes were all normal. If you see the examination of the knee, his range of motion was normal. In inspection, there was slight deformity of the knee, but when asked, when we inquired about the deformity, he was saying that it was congenital deformity. So his leg was slightly bowing when he was young age, and there was no swelling or redness in the knee. On palpation, there was no crepitus, there was no medial joint line tenderness, and all the special test was negative. Ballotment test was also negative. So this ballotment test we usually do when there is any effusion in the knee joint. If there is any effusion in the knee joint, the ballotment test will be positive. In his lab report, his ESR was 13, his CRP was 5.4, uric acid level was 5.90, and but his previous uric acid level was 6.6. Okay, so for male patient, normal up to 7 milligram per deciliter is considered normal for uric acid level in male, but in female maximum value is 6. Uh, So on ultrasound examination of the knee, there was early osteoarthritis changes in the leg with small osteophytes in the medial joint line. There was no effusion, and cartilage thickness was well maintained. And he had an X-ray of the knee also. It showed grade 2 osteoarthritis in KL classification. And he had done MRI also before coming to me, and it showed mucoid degeneration of anterior cruciate ligament. Okay, so 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 normally regarding the diagnosis and management, so we diagnose this case as a early secondary osteoarthritis of knee. Here basically, why secondary osteoarthritis in knee? Because normally the patient is male, and he had everything normal, and in the history he was saying that occasionally he had a problem of high uric acid, and that can be a source of knee pain this time also. And on discharge, he was given duloxetine 20 milligram 2 times a day, paracetamol whenever he had pain. He was also given febuxostat 40 milligram OD, and we did platelet-rich plasma injection in right knee, ultrasound guided, and for about 5 ml of PRP was injected. And at the same time, advice was given to reduce his weight and to do knee isometric exercise and to do lifestyle modification. So in the management of knee pain, so this weight reduction, isometric knee examination, and lifestyle modification also plays an important role in management. I would say this is one of the most important role in the management of the knee pain. Sometimes what we do and what we see in our general practices, patients are not advised to go for weight reduction or go for knee isometric examination, or even if they are advised, they will casually advise, okay, you have a slightly overweight, please try to reduce weight or do this exercise 2 times a day. They usually casually give advice. But while managing a patient with knee pain, especially osteoarthritis, um, uh, weight management, knee isometric exercise, and lifestyle modification has a equal role if you compare that with medication. Okay, so 50% patient has to do their job. That means if the patient is obese, he or she has to consult a dietitian, or if they don't consult a dietitian, also they have to go for weight reduction. And we also have to focus in our OPD to tell the patient to go for knee isometric examination. If you see the various guidelines of United States or even of the Europe, they put more emphasis on weight reduction and knee isometric exercise, as well as lifestyle modification during management of pain. But here in my part of the world, all these three things like weight reduction, isometric examination, and lifestyle modification are not um, told. This advice are not given nicely to the patient, and they tend to not do these things, and they tend to rely on only on intraarticular injection of steroid or PRP or oral medication. So while managing, we have to focus on non-pharmacological method like weight reduction and so on, as well as pharmacological management with duloxetine, as well as platelet-rich plasma injection. Okay, so this is the case history of the patient. So if you see in the blue color, he had already had two steroidal injection 2 years back, which provided him 6 month relief. And in the same day, we did platelet-rich plasma injection under guidance of ultrasound, as his inflammatory markers were all normal. And we also focused on weight reduction, isometric exercise, and lifestyle modification. And this is 1 month after patient came after 1 month of the PRP injection, and he was saying that he was much more better with this conservative management of and along with PRP, and but his burning leg pain was still there. So in follow-up examination, we added one pregabalin 75 mg to the patient because of the burning leg pain in the patient. And on if you see the follow-up, he reduced 1 kg of the weight. Previously he was 92, and he came with 91 kg, and he had already visited a dietitian, and was under a diet plan to reduce weight. He was doing knee isometric examination 2 times a day, 2 times a day, and he was also doing lifestyle modification. Okay, so the conclusion is like with conservative management, he was getting better, and this conservative management was more evidence based management. So normally, what they say is nowadays, always go for PRP injection if indicated, or even go for other prolotherapy if indicated. And steroid injection, steroid is not done at all, and it is done only if it is wet knee. That means if there is effusion in the knee joint, or if the knee pain or knee osteoarthritis is secondary to rheumatoid arthritis or even gouty arthritis, having fluid in the knee, that is the only indication for injecting steroid in the knee, or even giving oral steroid to the patient. Okay, so if the knee is not, if there is no effusion in the knee, or if there is a minimal effusion in the knee, then first choice of management will be, along with the conservative management of lifestyle change, weight reduction, and exercise, platelet rich plasma has an excellent result. Or you can also go for like dextrose injection if the patient cannot afford like a PRP, or even go for ozone with dextrose injection in the knee. Uh, so this is normally the guidelines that we usually go if the patient is of osteoarthritis knee. First and foremost thing that you have to think is educate the patient. We have to tell the patient that this problem will not end. Okay, the knee osteoarthritis will not, this will gradually, it is non-curable disease. Because, and to cure this disease, 50% is patient's work and 50% is doctor's work. So 50% that is in patient's hand is, he or she has to decrease the weight or maintain normal BMI. He or she has to do physical exercise, mainly knee isometric exercise every day, 20 or 30 minutes in the morning and evening, and it is for lifelong. And he or she also has to do some lifestyle changes. Without these three things, if they only rely on medicine or injection in the knee joint, then that will not cure the patient. So here in the first visit, you have to educate the patient regarding the disease, how it progress, and what are the non-pharmacological management that is under the hand of the patient, which has to be done along with the medical management. So here you have to focus on these three things as well, not just focus on medicine as well as PRP. And there are other temporary measures like heat, acupuncture, and knee braces, walker or cane can be given to the patient. And you have to tell that patient that these application of heat, acupuncture, knee brace, walker, these things are temporary. This will take care of problem only for few hours, few days, or few weeks. This will not be a permanent treatment. And if you see the osteoarthritis grading, if it's early, that is grade 2 or 3, you can always go for prolotherapy by dextrose if the patient is weak, if the patient is economically poor, or you can go for platelet rich plasma injection, ozone injection, or even go for hyaluronic acid of 1 to 3% injection. So these are the recent trend of management of osteoarthritis instead of injecting steroid in the knee joint. And there are other temporary measures also. We can also advise the patient to go for the genicular branch ablation of the knee joint, ultrasound guided or CM guided. It has a excellent result if the pain, if the osteoarthritis grading is grade 3 or grade 4. And normally we always have to advise the patient to go for total knee replacement if it's grade 4 osteoarthritis. That is the gold standard treatment. If the patient is not willing to go for surgery, or if the patient is not fit for surgery, then radiofrequency ablation of genicular branches of the knee joint can have an excellent result in grade 3 and also in grade 4 osteoarthritis. Okay, so so in pharmacotherapy, we tend to rely on non-steroidal anti-inflammatory drug in osteoarthritis, which can be oral, like oral paracetamol or ibuprofen or naproxen. We can also advise patient to go for application of topical non-steroidal anti-inflammatory drug. And tramadol or tapentadol has an excellent role in these osteoarthritis knee, because the pain will not end. Okay, so these tramadol or tapentadol can be taken for a long-term period without any adverse effect in the kidney. And duloxetine is an excellent drug, especially if you are treating chronic pain, like in this knee osteoarthritis. Then duloxetine has an excellent result. But in my part of the world, what is the main problem is before giving duloxetine, patient usually think that it is a anti-anxiety drug and antidepressant. So patient will usually have phobia, and they will not want to have duloxetine. So I advise everybody before prescribing duloxetine, tell what kind of drug is this. You have to tell the patient that I am giving you drug. Okay, so this drug is actually antidepressant or anti-anxiety, but I am giving this drug to take care of your chronic pain. I'm not giving this drug to decrease your anxiety or depression. Okay, but if you say this thing in by yourself in a OPD, then the patient will have a positive impact. But if you just prescribe duloxetine, and if the patient goes to the pharmacy and pharmacist says that the doctor has given you antidepressant or anti-anxiety drug, then the patient will have a negative impact, and they tend to not take this duloxetine. Okay, so while prescribing, you always have to, during management, you have to tell what kind of drug is this and why the patient is giving these drugs. And sometimes, like topical capsaicin has also a good role in pain management. Chondroitin has also shown some in some guidelines to have a good efficacy. And coming to steroid, okay, so here steroid, normally it is a common practice by the doctors to give oral or intra-articular steroid as a first line of treatment in managing knee pain. Actually, it should be completely avoided. And steroid, either oral or intra-articular, should only be given if there is any effusion in the knee joint, moderate to severe effusion, or if the knee joint is wet knee joint. Usually it happens in secondary osteoarthritis due to inflammatory arthropathy. And sometimes surgery should be done. It is surgery, total knee replacement or partial knee replacement is a gold standard treatment in grade 4 osteoarthritis. Okay, but if the patient cannot go for surgery, or if the patient is unwilling to go for surgery, or if the patient is unfit to go for surgery, then we can always go for genicular nerve ablation of the knee joint for the management of the patient. Okay, so thank you very much. So this is the three cases that we commonly come across, and various mismanagement done by us as well as our colleague. So we can discuss these three cases regarding the management, sir, now. Hello.
Yes, serious.
Yes, sir.
So the forum is now open for discussions. Any questions? So what is very important, why we have given these things, that we should not call or blame that okay the mistake, but the thing is the awareness is needed, and the management, there are a lot of recent advances in the management, non-surgical the aspects that has to be emphasized on with the real scientific information to our patients, and the patient, let the patient choose which one he want to opt for. So these are the areas where we should be making patients much more aware. So any questions regarding these three cases or any other similar cases which you are facing, you also can share. If you are having, if you are knowing similar kind of cases, you can also share your cases.
So actually, sir, this first case is the student who is doing basic right now, sir. She is a doctor, anesthesiologist, and after this case, she was very much impressed with the non-surgical treatment in pain management, and that was one of the driving force for her to take pain management as her future career. And in both cases, she was not given any like epidural injection or ozone nucleolysis. This alternative modalities was not given to her. Directly surgery was given, and even with two surgeries, she came with disc prolapse in 2020 also with similar problems. So this is one of
So
the.
this is very, very important, and what we told earlier also, that is also one of the thing that many a times the monetary gain is one of our driving force to go for a treatment modality. That should never happen. I always tell all our fellows at Daradia, we always tell that the monetary gain should not be considered in any way whenever you are treating a treatment modalities. Right now I can share one of the patient. Just day before yesterday we saw this patient. This patient was referred by one of the neurologist, and referred him for the endoscopic discectomy. So patient was have given taken the quotation. Patient was ready for the procedures, and when we examined the patient, we saw that the patient has in no neurological deficits. The patient is having the claudication, and we had a fresh MRI, and there we saw that the disc height is terribly reduced, less than half of the disc height to the adjacent areas. So now, if we are going to do the discectomy in these patients, where the disc height is lost, without doing a laminectomy or without doing a fixation, this patient will be definitely landing up with some complications, like the claudication distance might be reduced. The patient might be going further because of the ligamentum flavum buckling. If you are removing the disc material is compensating somewhat. And if you are removing that disc, the buckling of the ligamentum flavum will be much more, and the patient might be landing up with the, though the patient was ready for the procedures, we didn't do the procedure. So this is what is very important, that we all our rational thinking, with all of the justifications, we should decide the patient's treatment, and monetary gain should never be a factor whenever we are deciding it. We have to think for all the things what is open there. It can be a conservative management, it can be a very simple interventions, and the other options, and let the patient decide that what is the best for him. And we should give the scientific information, like as you told earlier, that if we are looking about the natural history of the prolapse disc, even if we are not doing anything, what is the chances of recovery? Chances of recovery is more than 80%. So that is the medical, that is the rational information what we should give to our patient, and let the patient decide what to do. Okay, any questions or any other case you wish to share with us, with the other participants, you can say.
So one doubt regarding the knee pain, sir, where you said the uric acid is high and you started Febustat. Again, after 1 month, the patient was having less symptoms and you stopped Febustat. Uh, uh, it just having a high uric acid, should we start Febustat and we can stop it after the 1 month, sir? Like on
No,
what
actually,
grounds?
actually, the proving that only the raised uric acid is not enough to tell that this is a crystal arthropathy, because the crystal arthropathy can be diagnosed only with the polarized light, with the uric acid crystals, or sometimes by the ultrasound, say looking at the gouty tophi. These are the only way to make a diagnosis of the. Otherwise, the chances of uric acid deposition, crystal deposition is always there. And the recommendation is, anybody who is having the high uric acid level, we should give this some of the uric acid lowering drug, because the chances, even if the higher uric acid level does not mean that it is going to always create a crystal arthropathy, but it is recommended that if the uric acid level is higher than the normal, then the diet modification and the uric acid uricosuric drug should be prescribed to lower the uric acid level, and it should be followed up to look if the uric acid level is coming normal. Then you can stop or you can taper off the duration. So series can tell what was the the
So
plan in this patient.
yes, sir. Here I have shared the screen, sir. Here I have also, if you see the lower part, blood test uric acid. I have also given an advice to the patient. Whenever he checks uric acid, if it's more than 7, then I have advised him to take febuxostat 80 mg. And if the uric acid level is between 5 to 7, decrease this dose to 40 mg. And if it's less than 5, I have advised him not to take medicine and only go for a dietary restriction. So this is the common instruction that I usually give to the patient. And since his uric acid level was also not that much high, it was about 5.90, and basically he had a history of higher uric acid, but the paper he was presenting to me had a maximum of 6.6. Just to take care. Maybe in case of in case of acute gout, like when you see the uric acid, it can be normal also. In acute gouty attack, if you just see the uric acid level, sometimes it will not show higher uric acid, sometimes it can be upper normal. So in these cases, just not to take chance, I just gave him febuxostat at the first visit. But in second visit, once the pain is less and uric acid level was also normal, I basically withdrew the febuxostat and just give him duloxetine and pregabalin for his neuropathic pain and the knee pain. So that is the normally done practice, the regularly evidence-based practice. So sometimes if you see patient with acute gouty attack also, sometimes the uric acid levels can be less than 7 in male or less than 6. In these cases, we cannot judge the uric acid gouty attack only with uric acid. You have to correlate with the clinical signs and symptoms also. So here, because the uric acid level was not high, I withdrew the febuxostat, but I gave him advice to check uric acid level in every 3 months or even 6 months. And if the uric acid level is high, to take medicine as per instruction given in this paper. As you can see, just in the lower side, I have given
Yes,
you.
yes, yes.
Yeah.
Everything is clear. I think
Yes, sir.
Sneha, the things is clear. So uric
Yes, sir,
acid level,
understood.
uric acid treatment is a continuous process. So you have to check it, and you have to, the continue the doses as well as the dietary restriction depending on the uric acid level. It's just like that of the treatment of the diabetes, that you have to,
So we need not always do a crystal study, synovial crystal
No,
study
no,
to
no, that
start
is not
febuxostat.
needed because that is not available. That is costly. The clinical aspect, clinical diagnosis with a raised uric acid level is a normally what prompts us to take the decision. But even if the patient is clinically asymptomatic, if the uric acid level is higher, we should treat this patient because there will be more chance of crystal arthropathy in these patients. So if any patient who is completely asymptomatic, but uric acid level is high, should we treat this uric acid level or not? Answer is yes, because the chances of the uric crystal arthropathy chances will be increasing in these patients.
So regarding the same case, so sometimes urate crystal, this crystal, so depositions are seen in the X-ray film, simple X-rays,
Yes.
knee X-ray. So should we like, sir, in gouty arthritis, this PRP and RF are like, sir, similarly indicated, or they have a different indication?
Gouty arthritis, the PRP is not an indication. Gouty arthritis, the treatment should be conservative with the lowering of the uric acid level. This is the treatment that is recommended. If this patient is associated with the osteoarthritis or other things, then you should be thinking of it in the treatment. If it is purely crystal arthropathy, then you manage it conservatively.
Sir, how to know like it is like purely crystal arthropathy?
You have to judge with the other symptoms. The crystal arthropathy symptoms is always very acute, very fulminating. The sudden onset with the redness, swelling. It is very it confusion with the infective arthritis. Septic arthritis is one of the differential diagnosis. The cellulitis. So this is a very the sudden onset with the swelling, with the signs of the inflammations. So this will be
Okay, sir.
prompting uric acid crystal arthropathy is always a clinical diagnosis.
Okay, sir. So one question regarding the first case, sir.
Yeah.
If the patient is having canal stenosis and having no neurological deficit, no claudication, nothing, so is like in canal stenosis, epidural injections are like, sir, how much it is beneficial to the patient?
If there is no symptom, we are not treating MRI.
No,
You
sir,
say,
patient is having pain, but patient is having pain and MRI finding is showing canal stenosis.
okay.
Should
You
we
see,
advise
you
the
see, the thing is, the pain has the canal stenosis symptoms should be what? What is the definition of the canal stenosis?
claudication,
Definition of the
sir?
canal stenosis is
Claudication.
claudication. Claudications or neurodeficits or both with reduction of the canal size. This is the definition. That means if the patient
Yes,
don't
sir.
have any neurogenic claudication, if the patient don't have any neurological deficits, only canal diameter reduction, we don't need any, patient don't need any treatment. What Dr. Siris was telling, that we are not going to treat our MRI plates. But suppose if this patient is having the claudication or neurodeficits, Mild neurodeficit, not the severe neurodeficit. Severe neurodeficits, surgery is the choice. So if the mild sensory or mild motor weakness is there, then epidural steroid is one of the evidence treatment.
Until
Okay.
unless there is no neurological deficit, we can go with
Mild neurological
epidural steroid
deficits, you can
injection.
go ahead with the epidural steroids. Mild, like grade 4/5 motor weakness, mild non-progressive sensory deficits. So these are the neurological deficits where you can go ahead with the interventions. But if the motor weakness is more than 4/5, if the sensory deficits is much more and progressing, so these are the conditions where you cannot go for the interventions. Say there the surgery is the choice. But otherwise, what we have to always remember, the asymptomatic, if there is no claudication, no neurodeficits, even if the canal stenosis is very severe, very tight, we need not do anything. But if the patient is having the claudication, most common thing is your claudication, then epidural steroid is one of the very important treatment options. If it is a bilateral symptoms, then the either caudal epidural or interlaminar epidural, and if it is an unilateral symptoms, then the transforaminal epidural is the choice. Okay.
Yes, sir. Yes,
Sir,
sir.
regarding the greater occipital nerve block, sir.
Yes.
Sir,
Yes. Tell.
sir, is the site of giving the block is the same, sir, what we give in PDP, the scalp block patient, sir? So like
Scalp
behind the
block.
mastoids,
Nowadays we all do it under the ultrasound. With the ultrasound, if you are
the
not
way should
attending
be
any,
approached in the ultrasound also, the way should be like approached, sir.
what I shall do, I'm just sharing one of the videos there in our YouTube channel, how to find out the greater occipital nerve. Hot series already mentioned there. And series, do you have the video? Then you can share it. So
Yes,
it
sir.
is
I have video. I'll share
So
it,
you have
sir.
to locate the C2 lamina, and above the C2 lamina is the inferior oblique muscle. Above the inferior oblique muscle is your semispinalis capitis muscle. So in between the two layer between the semispinalis capitis and the inferior oblique muscles runs the greater occipital nerve. So that is the muscle plane where you should go for the injection. But what I am going to tell you, I am just sharing a video with you, and where how to the sonoanatomy, how to scan the posterior neck, and there how to find it out, and there you can go ahead with that. I hope all
There's a
of you,
pro
the Daradia YouTube channel's subscriber. We have a lot of videos there. You can go ahead with all those educational videos. Series, you can share your videos, what you have done.
Yes, sir. I'm trying
sir,
to
the
get.
probe should be placed near the C2, sir, C2 lamina.
Yes, it should start from occiput. You can slide down to find out the C2 lamina.
Okay, from
First
occiput.
C2 spinous
Okay.
process will be the first bifid spinous process. That is how you know that this is the
Okay,
C2.
sir.
And then you go laterally to the affected side, and then you make the probe little oblique in the long axis of the muscle, inferior oblique muscle. I'm just sharing the video. You just go to that.
Okay, thank you.
Sir, one question regarding knee pain, sir.
Yes.
Sir, generally we advise radiofrequency ablation for the third and fourth degree of fourth grade. Sir, why don't we go for ablation in first or second grade or third grade like that?
First and
Just
second grade,
PRP.
we try to reverse the disease condition. If you can reverse the disease conditions, so genicular nerve block ablation is not a reversal of the disease disease process. So if you can reduce the disease process, which is very much possible in the grade 1, 2, 3, so that should be the first choice, isn't it?
Yes, sir. Sir, is like a PRP is also indicated in osteoarthritis of the shoulder joint.
Yes, we can. That is one of the indication. Okay, series, you can explain the layers. You can stop the video. You can explain the layers, and you can go ahead.
So here you can see there are, so this is the lower white shining part is the lamina of C2, and this just above this black hypoechoic muscle is inferior oblique. Just above it is like splenius capitis, and above it is like trapezius, and skin and subcutaneous tissue. So these are the layer, and basically between the semi-spinalis capitis and inferior obliquus muscle, this is the plane where the greater occipital nerve lies laterally, and medially third occipital nerve lies. So here what we have to do is we have to scan at the occiput and come down and get bifid lamina of spinous process of C2. Once we get bifid lamina of C2, then we tend to move the probe more laterally towards the lamina and arrange the probe along the long axis of inferior oblique. That means we basically rotate our probe so that the probe becomes along the long axis of the inferior oblique. And when we do this, we will distinctly see these two layers of muscle, splenius capitis and the inferior oblique. So, and in plane, we basically you can see the needle coming in plane from here. So you can see this shiny needle, and I'm putting my needle at the junction between the inferior oblique, and here you can see the needle is just at the junction, this area, and gradually I'm depositing drug like 4 ml of drug slowly in this area. So this is the trapezius, this one is semispinalis, and this is inferior oblique. So here will be the location of the greater occipital nerve, and you can see the needle coming in long axis. And now I've deposited about 4 ml of drug in this area at the near the greater occipital nerve, and this is the procedure. Basically, you have to search a plane between semispinalis capitis. This picture was not intended to show in class, so it was taken very casually by the assistant. So it is not that big, but you can go to the YouTube video and see the how it is given. It's very nicely given in YouTube.
The 4 ml of lignocaine, sir.
1% lignocaine with 20 milligram of methylprednisolone. Total is 4 ml. But nowadays we are also going for only dextrose, 5% dextrose.
Yes, only 5% dextrose, and with 5% dextrose, you can increase the volume also. You can go up to 10 ml of volume. Steroid, you cannot increase the volume more than 3-4 ml. But if you are injecting the dextrose, then you can inject little bit more volume, which might be better, because nowadays the people world is going more in favor of the dextrose injection. But if you are asking which is having the more evidence, steroid has the more evidence.
So
Sir, in dextrose, we need to add lignocaine, sir. Lignocaine with
No,
dextrose.
only dextrose. Only lignocaine, you just give the infiltration of the skin, and after that, dextrose in the two muscle layer, in between the two muscle layer.
So you can just give 5% dextrose, about like 5 to 5 ml, then that will also take care. Here, I could not take risks because that patient was suffering too much and he was visiting lots of places. I was very reluctant to give steroid, 20 milligrams steroid. But if that patient was from my place, I would have definitely go for dextrose as a first choice of drug. But since the patient came from far away and I could not go for repeated injection, I opted the option of steroid. That was the only indication. Otherwise, we usually go for 5% dextrose also, 3 to 5 ml. Nowadays recent evidence guide us, like evidence are there of very like nice result with 5% dextrose also.
Hello, sir.
Yes.
Sir, I have one case to discuss, sir.
Yes,
Uh,
go ahead.
I got
Tell.
one 70-year-old male patient
How
came with
much year? How
bilateral
much year?
70,
70. Okay, okay.
came with bilateral knee pain since 10 years. And
Hmm.
he had a stiffness also. And he is also known case of HIV positive since 10 years. But why everything blood parameters were normal. He was on the no other systemic infection, nothing. He was on regular medications and all. He had severe knee pain, and he was like, "I'm already 70 years. I don't want surgery. Please do something for the knee pain." So I first opted for hyaluronic acid injection bilateral knee with the 20 mg of steroid with both each divided. And after that, after 24 hours, he called me again and said, immediately after the injection, pain was reduced. After 24 hours, he called me and said, "Ma'am, the pain is increasing like that." I said, keep rest, take rest, and will observe. If it is increasing, visit me and them. And that pain has increased more and more and more. And on the third day, he has visited me. I had scanned, there was no effusion, nothing was there. I thought because of severe stiffness or something he's having pain, and I tried to start physiotherapy, but that pain increased more, and pain was severe. So I admitted the patient and I started IV analgesics and all. Then at fifth or seventh day, again I scanned because there was a visible swelling, and I saw there was an effusion collected a bilateral knee. Left was more than right. So I saw that effusion. I thought it is an infective or septic arthritis or something, and I immediately aspirated the fluid and sent for cell count culture and all. The cell count, I got the report immediately. It was looking more of inflammatory thing, but better to add on antibiotics, and I added antibiotics, broad spectrum analgesics, rest everything we did. By the end of third day, I got the result of culture also. Culture was also negative, and eventually then I thought like this might be a reaction to hyaluronic acid, this thing and that. So what could have been done, and
So today
how
is which day? Today is which day?
it's already 2 months ago, sir.
So now the pain has subsided.
After 10 days, I had called him back for the visit after discharging. After 5 days of admission, I discharged. After 10 days, almost 15 days, then he came that the knee pain has reduced and now came back to that normal level.
And now
Before,
is it
it,
less than the
it's,
initial stage?
he has not yet come back, sir. The
Okay,
last
anyway, just one thing, remember, this is a rule. This is a rule that no pain because of the procedural infection will start within 24 hours. Write it down and remember always that again, I'm repeating. If pain increases within 24 hours of the procedure, suppose today we have done it and a patient is complaining, or the next day or the same day night calling you terrible pain, it is never ever because of the infection. So this is basically tissue reactions. Whenever you are injecting something, the patients might develop some, the reactions to that particular injectant, and can have this can happen with any of the injections. Sometimes even with the steroid injection, I have seen steroid is going to suppress it. Steroid is one of the treatment of this reactionary edema, but still steroid itself can cause, deposteroid itself can cause these things. I 2 3 cases I have seen or observed also. So few things you remember, that number one is it is never because of the infection if the pain aggravated within 24 hours. Number one. Number two is any pain what is injected, what is aggravated after few hours is always because of the tissue reactions. Some patients develop this kind of things in surgery also. After the surgery, the patient might be developing fever, very terrible increase of the pain. This is because of the tissue background product, which is the handling of the surgical procedure. So similar kind of things can happen in the interventions also. If you are injecting steroid, hyaluronic acid, PRP, growth factor, anything, any of these procedures, or whenever you are injecting, sometimes dextrose injection. So this kind of tissue reactions might happen. Always reassure the patient, apply ice, and give analgesics. If you have given PRP, this kind of tissue reactions, you cannot give the anti-inflammatory drug. But in this your case, because you have given steroids, so in these cases, you can give even anti-inflammatory reassurance and application of the ice. Tell the patient that normally these tissue reactions will be resolved spontaneously by a week or so. It plus minus 1 or 2 days. So always remember that nothing, never be apprehensive of infection. So I also was like you in my early days when this kind of things happened. I thought of infection. I did all the blood count, and the culture, and gradually I learned that it can never be because of the infection if it is within 24 hours. And nowadays, this kind of reactions, if the patient is calling us, I never get afraid. I never do anything. I just reassure the patient, and patient will be subsided in a week or so. Okay.
Okay,
Sir, can
like
I add
how
something,
to
sir, here?
prevent it, sir?
Yes. 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 Series. Tell.
So
Yes,
I
sir.
just want to advise Bhanusri that, and everybody, that don't go for intervention right in the first. Try to go for, think of other non-pharmacological or pharmacological, like like if the, like you can always go for a duloxetine, go for a trial, because osteoarthritis knee is a chronic problem. It will not heal by himself. So before putting needle into the joint, basically what happens is, when patient thinks of putting needle, they think that once we inject in the knee joint, then all the problem will be solved. But you have to understand that this osteoarthritis is a chronic problem. With a needle injection, it will not solve all the problems. So I advise to go slowly, like try to, in the first visit, try to educate the patient regarding the disease process. Try to explore the grading of the knee joint, what is grade 2, 3, 4, and what does it signifies, and go for other non-pharmacological and pharmacological, like weight reduction, exercise. Go for NSAID like paracetamol and duloxetine for initial management. And if the patient try to win the goodwill of the patient, and if the pain subsides, then tell him that prolotherapy and other therapies are also available to go for a long-term pain relief. And go slowly. Don't jump into the intervention right
So
away.
this is very very valuable advice by series, and always remember these things, that and those who are here in Daradia also, they know that we never jump into the interventions. This is not just for the knee, this is for anything. Let the patient earn the interventions. Let the patient beg for it. Then only you go. Never force. Never give any false promise. Optimistic view that okay, if you are doing these things, you will be cured. Never say these kind of things. You always tell the patients that this is one of the options. Conservative management is an option, surgical treatment is an option, intervention is another option. So before jumping into the surgical interventions, you should go for the interventional pain management. But before that, the patient should be prepared. Like I always tell the patients that okay, exercise, the duloxetine, take this kind of medication, prepare your knee for the interventions. So next, after 1 or 2 months, patient will be coming, and then you give the intervention, do the interventions. The result will be much better rather than we are planning to go for the intervention at the beginning. This is not just for the knee. Remember, this kind of thing should be in the almost every patients, except for sometimes some patients might be coming to you where all the conservative management has already been tried. Patient is terrible pain. Then in these situations, you might be going straight into the interventions. But almost always, in 90%, 80% situation, there still remains some scope of conservative management. Try to explore that. If everything has tried, then only you think that okay, this is the time where I should be offering interventional pain management before going for the surgery.
Yes, sir. That other than duloxetine, everything was tried by visited
Anyway,
many
this is just
hospitals.
a general advice from Dr. Series and also from me, that and this is for all of you who are there in the meeting, that remember that there is always some scope of the conservative management. Try to explore that. Nobody likes a needle prick. So try to explore the conservative management first, and then you plan for the interventions before going for the surgical interventions. This is as a
Yes.
general, you should be always
In this
remembering.
case, which drug to blame, sir? Is it the steroid or is it to
It is
the
difficult to say because it is a combination. If it was a only single drug, you can tell. But what I mentioned you earlier, that in my practice, I have seen only with the injection of steroid, patient's pain has steadily increased, and that lasted for approximately 5-6 days. I have seen this kind of things also. So both the drug can be responsible for it. Even the deposteroids itself can cause the inflammatory reactions. So mostly because of the preservatives. So this
can
can happen. This can happen.
can we blame it for HIV positive, more
No,
sensitive,
no, no.
anything?
That is not directly related to that. This is a tissue inflammatory reactions. This can happen in some of the patients.
Any patient. Okay, sir. Either
The
drug or
Delox.
Either of that can be blamed. It is difficult to say. People think that the steroids is an anti-inflammatory, how it can cause, but yes, it can cause. Particularly the deposteroid, which has the preservatives. The preservatives itself can cause the inflammation.
and in the management, anything extra can be done.
No, no. Whatever you have done, anti-inflammatory drug and the ice. These are the two
Mm.
things.
Okay, sir. Yes, sir. Thank you, sir. Thank you.
Sir,
Sir, in this connection, I want to add one more case, sir. One
Hmm.
patient, 38 years female, she came to me with pain in the heel. She is having plantar fasciitis from 3 years. But as she was going to US, she asked me for, I mean, anything is possible. So I suggested PRP, sir, and I have did a PRP injection. Then the patient, after a PRP injection, immediately within 2 hours, she had severe pains. She is unable to walk also, it seems. And I was so scared after that injection giving a PRP, and that pain was there till 10 days, and now still she's complaining pains. I don't know what might be the reason. She came later after 10 days. I saw ultrasound, plantar fascia. It was there. I thought I ruptured it, but it was there intact only. But still, she's complaining of severe pain. She's almost limping, sir.
Okay, gradually it will reduce. You please reassure them and gradually it will be reduced. One thing you should be remembering that the PRP action is always slower. So that initial inflammatory reaction, what is caused by the PRP, in fact, inflammation is being increased by the PRP injection. And sometimes this inflammatory reaction, again, let me say that PRP injection in few of my patients I have seen increased pain even 2-3 weeks after the procedure. And gradually it subsides. So this is not unusual, and that is the reason why whenever we are going for the PRP, I always tell the patient that initially your pain might be increasing. In some patients, it is very much comfortable, and in some patients, the pain might be increasing. And action of the PRP starts only after 1 month. You have to accept that. If you want a very quick result, then steroid is a better option because steroid normally in most of the patients, the pain relief starts within 48 hours. But that is not true for the PRP injections. So what we are sharing, this is also a common thing. I already mentioned that the initial tissue inflammatory reactions might be very severe in the PRP injections.
Sir,
So,
can I ask you a question?
Yes,
so will
yes.
there be any rupture of fascia like that? Is it possible, sir, with PRP injection, the procedure?
PRP injection rupture of the fascia is not possible. If unless injectant itself is causing it, it's extremely rare. The steroid injection can cause, but PRP injection, we can give PRP injection in the plantar fascia itself. It is recommended. And rupturing with the injectant and with the needle, it is not that easy that you are causing rupture of a fascia which is of that thickness and which is of that broad with some needle prick and with some injectant, and you are rupturing. That is basically is a theoretical possibility, not the practical possibility.
Okay, okay. So immediately the other day I called one of the pain physicians. They told might be you have ruptured fascia.
No,
That
no,
is
no,
the
no, no.
yes, they-
Rupturing PRP, rupturing fascia is extremely impossible. Extremely impossible.
So I was little scared, sir, after that procedure.
These all are initial inflammatory reaction, tissue
Sir,
reaction in response to any of the injectant. Yes, Dr.
Okay,
Suman.
sir,
sir.
can I ask one question? Sir, how do we decide whether we should go for second PRP or not, or second session or next session, or just one PRP is sufficient?
It depends
In knee
on the if you are,
osteoarthritis, basically.
yes, yes. If you are looking about the what happens after you are giving the PRP or this kind of things, that it starts the process of the regeneration starts only after 2 weeks, and it goes peak in around 1 to 2 months, and it continues till 3 months. That means the PRP tissue regeneration, we have to wait for 1 to 2 months to decide whether the patient, at least 2 months, to decide whether we should go for the. Earlier, we used to repeat it after 1 month. Even then, I have seen many patients where the improvement continues beyond 2 months. So you, after you have given the PRP injections, wait for at least 1 to 2 months, and then you decide whether you'll be going for the next dose or not. So if the patient has a more than 80% relief, don't think of the second injection. If the patient is having the partial relief, then you can go ahead with the second one. And after that, again, you reassess the patient after again 1 to 2 months, and then you decide whether you should be going for the third injection or not. Don't go anything routinely that okay, one injection I'll be giving. I have even seen in the from the conference, people used to say that okay, I used to repeat this every 2 months, 2 weeks. Never do that. PRP action starts only after 2 weeks. So never repeat before 1 month. And earliest you can repeat it only after 1 month. And that too after the good reassurance, the good assessment to see how much relief is there. If there is no relief at all, then you should not be think of repeating. Then you should be ask the patient that, okay, PRP didn't work for you, so you are the right candidate for the surgical procedures. So don't reassure and don't, don't tell the patient guarantee that, okay, PRP is always going to help you. You tell that, okay, in 70-80% patients it helps, but in 20% patients it may not be at all helpful. And in those situations, if there is no improvement after 2 months of the first injection, then you should be going for the surgery. If there is a very good relief of more than 80%, don't go for the second. If there is partial improvement, go for the second. If there is no improvement, don't go for the second. Send this patient for surgery.
So for surgical advice, at least we should wait for like 2 to 3 months at least.
At least.
Yes, sir.
Then my
Yes,
question was on similar lines. Uh, Pain during injection or immediately after injection of PRP, whatever acute pain the patient has, does it have any relation with the way PRP is prepared, sir? Whether we are using single spin
Yes,
method
some
or
some 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 relation is there. It is particularly important. Uh, what anticoagulant you are using. Earlier when I started PRP almost, 12 years back in 2010, 11, 12, in that time, we used to give the triple citrate. Triple citrate was the anticoagulant, which was having some studies that time that the triple citrate can activate the PRP platelets and gives better result. So we used to give the triple citrate injection that time, and almost every second patient or every the two patients in three patients was complaining of the severe increase of the pain. So I was wondering why this is happening, and then ultimately we could realize that the anticoagulant have very important role. What anticoagulant we are mixing. So later on we switched over to, and also the published literature also said telling so. So if you are using the acid citrate dextrose, which are used for the blood transfusion, the same anticoagulant is used for the blood transfusion. So ACD anticoagulant is a anticoagulant where the post-procedural pain is not there. So definitely the one of the option that, okay, what anticoagulant you are using. This is number one. Number two is that how you are preparing it. If your preparation contains some WBC or RBC, both of them can cause the more tissue reactions. Means that if you are comparing with the patient where the WBCs are there versus no WBCs, and where RBCs are there or no RBCs, so pain might be aggravating. But again, this is not universally accepted. Some paper says, okay, there is no relation if some RBCs or WBCs are there in the PRP. So the thing is controversial. We really don't have any idea which patient will be showing the initial more inflammations after the injection of the PRP. But definitely anticoagulant is one of the factor what is proved, and I also experienced it, that the triple citrate is one where the patient's tissue reaction is much more compared to that of the acid citrate dextrose. Another thing, important thing what I have observed, that if you are adding, again, this is, I'm not based on the published literature, I'm telling this based on my personal experience, that nowadays I always add the hyaluronic acid. Whether you are using the 1% or 2% or 3%, whatever hyaluronic acid you are adding with the PRP, your tissue reactions and initial increase of pain will be much, much, much minimized. So nowadays in our Daradia, we always use, at least if the patient cannot afford the high concentrations hyaluronic acid, we always tell that at least take the 1% hyaluronic acid, which is very less costly, which will be, initial, that it is having the dual benefits. One benefit is it is a platelet activator, hyaluronic acid, so it will be potentiating the patient's response to the regeneration therapy. And second important part is it is going to minimize the initial pain after the procedure. So nowadays, and also it is also having the lubricant action if you are injecting in the knee joint or other joint. So these are the reasons why we give the hyaluronic acid. And my observation is In fact, it was my thought. I am forgetting to tell my fellows. Those fellows who are there in this group, they can think of this study that the PRP with the hyaluronic acid and PRP without hyaluronic acid, and see what is the post-procedure pain and how long it persists. My observation is that if you are adding hyaluronic acid, then the post-procedural pain will be much less than if you are injecting PRP alone.
Sir, if we
The
are doing
both at the same time at the same sitting, both PRP
Same
and
sitting in the same needle,
one by one. Acha,
one by one.
same needle, same one by
Same
one.
needle. Yes, yes.
Sir,
Okay,
if we are doing a single spin like we are doing at Daradia, so we are including WBC in the
Right. Some studies says if you are including the WBC, the chances of your the tissue reaction is more, but it is not universally accepted. But some paper says like that.
then in double spin, sir, we are still I
In double
think
spin, we are removing the WBC also.
so. In fact, I mean not as general, but for double spin, actually the pain should be less.
Less,
Like
right.
okay, so because these days I'm doing some cases and I'm not sure why some patient, not every patient is having post-procedure pain, but one patient was having, first day he was having so much pain that he called me twice or thrice. But then I had to give tramadol plus acetaminophen, and then second day he was better, sir. But first day he had a lot of pain. So I was just
This
and
can
sir,
happen, and this can happen in some patients. I know, but still, rare, but at least once in a month, I get this kind of things that okay, patient is telling okay after doing the
pain
PRP, my pain
during
has
the
increased.
procedure, like we are reaching till the joint, and then when we start injecting the PRP, the patient is having pain. So, is it due to grade
It is
4
because of
patient
the, I
having
have observed this kind of
osteophytes
thing can
or
happen. Yes, I'm telling, I got your answer. Got your question. That when you are doing the procedure itself, sometimes when you are seeing the needle inside the joint and you are starting injection, that time also patient complains the pain. And
yes, sir,
this
exactly.
happen when there are synovial hypertrophy inside the joints. Whenever the needle is touching the hypertrophic synovium and your injectant flow is basically touching and causing the movement of the synovial hypertrophic synovium, then in the patients might be experiencing some pain during the procedure. So this can happen. I've seen this kind of patients.
And if you do under ultrasound, pain is very less, sir. If you see do
Yes,
the
if you are try to find out the space where your needle is not touching the synovium,
I
you
know
place
this.
the needle in such an way that the needle is exactly in the fluid, in the synovial fluid. Then the injection pain will be much less.
Okay, so one patient I did, he was having some effusion, little bit of fluid in suprapatellar region. So that patient did not have much pain while injection. But recently I did one through medial patellar retinaculum approach. So and that patient also had grade 4 osteoarthritis. But pre-procedure she was not having any synovial hypertrophy much or no much effusion. That is the reason I had to do medial approach, but she was having pain when I started injecting. So that's why I got this question.
Okay, one thing you remember that you know this happened to me as well in several cases. But more and more case you will do through the piercing the medial retinaculum. You will be understanding that the procedure is very simple and it should not produce pain. Why the patients produce pain in the medial retinaculum approach is if your needle angulation is little more, there is a high chance that your needle is touching the medial condyle of the cartilage of the medial condyle, and
Okay.
that causes pain. Be
That's
sure that when you are doing, sometimes this can happen that suddenly your needle tip is lost from your vision, means ultrasound you cannot see the tip of the needle, and it might have touched the medial condyle, and that causes pain. So be sure that your angle is initially very shallow, almost horizontal, and then gradually you increase the so that you are not touching the articular hyaline cartilage, and that will be making your procedure absolutely pain free. If anytime if you are touching the medial retinaculum with the condyle, they will be having pain. This chance is much less if you are doing the suprapatellar recess approach, because the articular hyaline cartilage is not nearby. So less chance of touching these things there. So medial retinaculum approach, this possibility is always there, and always be cautious that we are not touching it. Okay.
Okay. Okay.
Sir, if we go by evidence based, which should we recommend PRP injections in grade 3, 4, or just purely in grade 1 or 2?
You can go for the grade 3 and even grade 4. Have you gone through the our publications of the PRP in the knee? What is the evidence-based guideline? Have you gone through
No,
that?
sir. No, sir.
No. Okay, I'm just sending you the journal link. You just go through that and you download the article and you read it nicely and you see what are the indications when you should go with evidence-based guidelines. So I'm just sending it. Okay.
Yes, sir. So
And
similarly, in like osteoarthritis, I saw a patient with osteoarthritis of the shoulder joint, sir, but it was like severe osteoarthritis. So joint line was fairly reduced, and the patient has this frozen shoulder. Like in this patient, is PRP going to help or?
Earlier, a chance of success in the grade 4 where the joint line is almost touching is less. Earlier, 1 year back, I always used to tell that this is the cases where you should go for the surgery. But nowadays, with the newer experiences and newer evidences, even in the grade 4, you can try the PRP and the visco supplementation if the patient's range of the motion is well maintained and if the patient don't have a gross deformity.
I'm asking for the shoulder joint, sir.
We joint, shoulder joint, it's same thing is
Yes,
applicable.
it is
sir.
said
If
that yes, sir.
sir, if it is advanced, then can I give a patient of the option of the RF
Yes, if it
ablation
is
or?
an advance, then only PRP may not be helpful. Sometimes we combine, sometimes we go try. So in the advanced osteoarthritis, both shoulder and the knee, definitely the nerve ablation is one of the choice.
Just to reduce the pain. It's not going to
Yes,
help otherwise.
right.
So
Sir,
one more
uh,
question.
Gayatri.
Yes,
If the
So
yes,
PRP,
tell.
yes, PRP injection is not only to reduce pain, it also improves the function, it also improves the range of motion. So, like, we should not always think of reducing pain. It also improves the function. So, like sir said, you can give in grade 4 also. It has other benefit also. It might improve the stiffness of the patient, or it might improve the range of motion of the patient also. So, it is like a teamwork. PRP will be some benefit, not if it's not beneficial for the pain, if it's not reducing the pain, it will definitely have other action like improves the function of the joint, improves the decrease the stiffness of the joint. So these functions are also there with PRP, not only pain reduction.
so
So good
one
evening.
query, sir.
Sir,
Yes,
So
go
can
ahead.
it be possible? His age is 72 and the stage of osteoarthritis knee is stage 1. And
Yes.
we'll do PRP and it uh, can it work?
I didn't hear your question. I was actually basically sharing that this is a very important guideline. You can all download this guideline and you can read it.
she
Uh,
was she was
So
asking.
the age is 72 years and the grade of osteoarthritis knee it is grade 1.
hmm.
Can we do PRP here? Can it be
Uh,
possible
One
to
thing
do?
you have to remember, grade 1 osteoarthritis rarely causes that much of pain. So you have to rule out the other possibilities. One of the common possibilities is your inflammatory arthritis and some other things as also. So if the grade of the osteoarthritis is 1, always, if I always tell our fellows here that try to see whether there is a mismatch between the grade and your pain. If it is so, then you have to rule out the other possibilities.
Sir, actually, the patient age was 72 years, and X-ray wise, the grade was 1 only. And on examination, there was mild effusion, and he complained of a sudden onset of pain since 5 days, and only one limb. Uh, so I was like confused to give PRP or to give.
Series conveyor,
Uh,
sir. Suddenly I am having cup.
Um, Grade is grade 1 and unilateral knee pain.
Yes, sir. 72 years old, sudden onset of knee pain since 5 days. Minimal effusion in the knee on ultrasound scan.
Yeah, like sir said, we have to correlate whether the age and knee pain and the grade matches or not. So, like sir said, if grade 1 usually doesn't that cause that pain, it can cause pain, but occasionally it will cause pain when the patient is doing heavy work, going up and down too much. That can cause pain in grade 1. But here, I think you have to explore other, you have to broaden your diagnosis and might think of other causes of knee pain also, like other inflammatory causes
Yes,
of.
and another thing, series history is only 5 days. So
Uh,
osteoarthritis is normally a chronic condition with a long history. If the 5 days history is there, one of the condition what has to be ruled out in this age is your crystal arthropathy. So crystal arthropathy should be ruled out. Other the ligament sprain, tendinopathies. So this to be ruled out. The meniscal injury. Sometimes at the old age, you don't need that much of trauma, very mild rotation, very mild trivial trauma which patient cannot remember. Even that can cause the meniscal injuries. So these are the things what we have to think for, check for. If needed, you can go. Osteonecrosis is another. Osteonecrosis at this age can happen without any significant trauma. So if the patient is having the any the osteoarthritis grade 1, 70 years, 5 days, acute onset pain, you should have an MRI of the knee joint also. Don't think osteoarthritis as a fast diagnosis.
Yes,
So
sir.
you have to
MRI
know
was
the other
done,
things.
and
Hmm.
there was minimal medial and minimal meniscal injury. Other than no, this thing was
So
there.
maybe that is the as I telling you in the older age because the meniscus becomes soft. So the very minimal trauma or even the no trauma can cause the meniscal injury. So but don't because the patient is having only 5 days history, don't think of PRP in these patients because patient is not having a long standing problem. So here you treat this patient conservatively with ice with anti-inflammatory drug. If the patient is not having good relief, then I will be preferring rather than giving the PRP, I'll prefer the steroid with the viscous supplementation in this patient because this is a very recent onset pain and osteoarthritis grade is very mild at the 72 years of age. Grade 1 osteoarthritis will be more than normal. So all patients, if somebody is having no pain of the knee at the 72 years and we are collecting 100 such patient who never ever had any knee pain, and if we are having the x-ray of all these patients, everyone, each and everyone will be having grade 1 osteoarthritis. So the osteoarthritis may not be responsible for the pain in these patients. It may be the meniscal injury or sometimes ligament injury, but MRI has been done that has ruled out any ligament injury also. So I'll be telling this should be going in favor, and also the gouty things also should be ruled out in other patients. So these are the things which you should be remembering.
Okay, sir. Okay, sir. Thank you, sir. Thank you so much.
Sir, good evening. Sir, I have a question, sir. Sir,
Yes.
you just explained us that in comparative, you suggested a comparative study of using, sir, using comparative study between PRP alone and PRP with HA, sir.
Yes.
Sir, I had little confusion. Are we going to? You said in the the same needle prick, we will use both the drugs. I could not understand that. Can you please explain it again, sir?
We do it very frequently. We put the needle inside the joint in the synovial sac, and then we inject hyaluronic acid, and then PRP with the same needle. Needle will be the same. We are not changing the needle. We'll be giving the two injections one by one. Okay? Understood?
Sir, my question is, so in one patient, we'll be using either PRP with HA and the other patient will be with only PRP to compare
Right,
these. Sir,
right. And you can compare the two things in these patients. One is what is the post-procedural pain. I told you the post-procedural pain in the PRP plus HA is much less according to my observation. So this will be the very simple study. No long term is needed. You can complete the study maybe within few months only. You can take the 50 patients and you can go ahead with the post-procedural pain, because post-procedural pain you have to count only for the next 1 week. What is the post-procedural pain? And you can compare with the post-procedural pain with the adding the hyaluronic acid, because in some patients, this is observation by all of us who are doing PRP, that in some patients the pain might be increasing, in some patient it is not, but in some patient it is increasing. So my experience is, once we have started injecting HA, the chances of the post-procedural pain is much less.
Thank you, sir.
One question regarding first case, sir.
Yes, go ahead.
Sir, whether we should combine in PI cases of PIVD with radiculopathy, whether we should combine with the transforamen epidural steroid injection with ozone nucleolysis, or matlab, should we go with both, or?
Yes. It is always recommended, because nerve root is the most important thing. No, nerve root inflammation is the most important cause of the pain, radicular pain in the PIPD patients. So the study says that only steroid and steroid plus ozone gives more anti-inflammatory action over the nerve root. This is number one. And number two is injection of the ozone in the disc prevents the recurrence. If you are telling that what is the benefit of adding only epidural steroid and ozone plus steroid, the answer is, if you are doing the ozone nucleus at the same time, then the future recurrence will be prevented. Otherwise, what will happen? Once the steroid action is over, again the patient will be experiencing the similar kind of pain. But if you are adding ozone inside the disc, then the disc will be shrinked, and the recurrence will be prevented.
Sir, is there any link between quantity of blood and quality of PRP, sir? The number of platelets we get? Quantity, I mean, much, maybe if we take
Yes,
20.
if you are taking the more amount of the blood, and if you are concentrating it more, then the concentration of the platelet will be increasing. So now again, the thing is, it should be between the 6 lakhs to 10 lakhs. If you are concentrating too much, then it is having the negative effect. Some study says that if you are giving a very high concentration of the platelet, that might be having the negative effect on the regeneration therapy. So the moderate amount of the concentration, around 6 lakhs, that is the best the option. So you should be increasing the platelet count. So not sorry, sorry, sixfold. Sorry, not 6 lakhs. Sixfold. Sixfold increase is good enough.
That will make how much blood we should, how much blood minimum?
Pardon?
How much blood, sir? Minimum, how much blood we can withdraw?
Normally, what we do in our center, that we take.
Disturbance is there, sir.
Yes, I have muted. So the normally you take the 11. If you are taking the 11 ml, then you should make it around 2 ml of the PRP. And if you are taking the 22 ml, then you can take around the 4 ml of the PRP. This is what we are following here. Counting the platelet is always not necessary and not recommended as well. But again, here one controversy is there, that whether the part what we are discarding, that means the platelet poor plasma, is there having there any effect? So this is one of the very important question, that some study says that the platelet poor plasma, what we are discarding, having a very good analgesic effect. So ultimately, what is important, that when you are injecting PRP in the synovial fluid, what is happening? Ultimately, these PRPs are getting diluted within the synovial fluid. So what is my perception, though there is no published literature on this issue, that it is the total number of platelet what we are delivering to the patient. It is not about the how much concentration you are giving. The total number of platelet, if you are giving it, and if you are not discarding and making more concentrated, it is don't have any the negative effect on the regeneration therapy, rather than it might be having a good analgesic effect in the post-procedural cases. So what I'll tell, that you take around 22 ml of per knee. Even 11 ml you can take, but 22 ml and give around 4 cc. It will be giving good results. What we are doing in our hospital.
Okay, sir, but a few things like this arsonist is there, they will keep it outside for half an hour and then centrifuge. Will that have the same?
There are a lot of things are there. I will be telling you, I have already shared this guideline. You go through the guideline. This is based on the evidences and the opinion of the senior practitioners. You can go ahead. But remember always these things, the evidence-based medicines and the guidelines always goes on changing depending on the recent publications. So only one or two publications is not enough to make something called recommendation or guideline. So this guideline is a recent guideline which we have prepared after searching lots of literature. You just please go through it and follow this guideline.
Yes, sir. Thank you.
Sir, regarding ozone nucleolysis, sir, aren't we ozone nucleolysis increasing the chance of introducing any infection or something?
If you are doing any disc procedure, this chance is always there. Whenever you are doing a discography, putting in a needle, well, this is chance is there. So you have to maintain all the strict asepsis. That is very, very important. If you are injecting anything in the knee, are you not going to increase the chances of developing septic arthritis?
Yes.
If you are injecting anything in the epidural space, are you not increasing the chances of epidural abscess? These are all noted complications. Like discitis is the noted complication. Epidural abscess after the epidural injection is a reported complication. Septic arthritis is a reported complication. So all these are complications are very bad. And you have to be very
Yes, sir.
cautious and you have to maintain the strict asepsis.
Sir, before doing all these procedures, I mean, we need to take a written consent for with the patient, from patient.
A written consent, institutional consent, and you have to, the things is patient's identity should not be disclosed, must not be disclosed. You have to have a written consent from the patient if the patient's identity is disclosed in any way. If the patient's identity is not disclosed, you don't need any consent from the patient, but you need consent from the head of the institution or HOD.
Yes, sir. So, sir, consent, like if there is any complication or something like that regarding, as we do in anesthesia, sir, we take high risk consent and all like that.
There is a consent formed by the ISSP, Indian Society for Study of Pain. Most of the pain practitioners in India, we follow that, the consent form. You download it from the ISSP's website and you follow it you just customize, put the name of your clinic and you follow that consent form.
Okay. Thank you. Sir, for ozone nucleolysis, we are going by the Cambian's triangle approach.
Yes, the traditional interdiscal discography approach, the same thing.
Yes, sir.
Okay, so good night for today.
Sir, I
And
want to
yes. Why are you silent? Tell.
So one patient is there. He came for actually for difficulty in walking and the leg pain since 10 months. He came to the neurosurgeon for surgery, but neurosurgeon referred it to me. Like patient is having pain on the night pain is more and on the lying down. Sitting is like. Somewhat relief. Standing, no pain is there, but while walking, he is unable to his gait is like short step gait with support, and hill walking is difficult. Imbalance is there. And all the tests are negative, like SLR negative, SI joint no tenderness, only tenderness over the paramedian right side. Bilaterally, he is having along the dorsum of the foot sensory loss. Like one right side is around 70% and left side is like 30%. 4 months back, he had some root block at L4 level and L5 level. 8 days he decreased the pain, and after that again he started having the pain. And now only night pain and the back pain is more, and difficulty in walking is there, sir. Paramedian tenderness only present.
So what MRI is telling?
MRI is like L3, L4 bilateral foraminal disc is there, and L4, L5 also.
So you see, looking at the distribution of the pain and the numbness on the dorsum of the foot. So it is the L4 and L5. So it can be possible because of the L3-4 disc. L3-4 disc can cause the problem in the L4 nerve root, and the L5 also, if it
So,
is the media, if it is the dorsum of the foot. Dorsum of the foot is supplied by the L5 and the L4, partly L4 and L5. So if it is matching with the MRI findings, then you should be thinking of giving the transforaminal at that level, epidural that level. You can go ahead with that. Again, provided the conservative management has failed. And otherwise, other option, if the disc is not that serious, other option is it can be because of the, particularly if it is a L4, it can be the psoas myofascial pain. Psoas myofascial pain, like the piriformis and the syndrome, mostly causes the L5 and S1, where the patient is having the pain in the sole and the great toe. But if the patient is having predominant pain on the along the medial malleolus and the dorsum of the foot, other possibilities L1, 2, 3, 4, so which can be compressed by the psoas myofascial pain. So these are the other psoas myofascial pain. So these are the other possibilities what you have to think for apart from the prolapse disc. So if the patient had got good relief with the L4 or L5 nerve root block, you can go ahead with the epidural again.
Actually, sir, after 8 days, he started having pain. Like I was thinking whether transforaminal root
If
block
the
they have
transforaminal is
4
not
months
giving
back.
good relief, and if the patient is having a recurrence of the symptoms, you can think of ozonucleosis of the L4-5 or L3-4 disc, or otherwise surgical discectomy.
But
That
the
means you have targeted the nerve root. Patient got the good relief for around 7-8 days, and there is recurrence. So that means your target was right, and you have to think something which is having the long-lasting result. One of them can be the ozone, or it can be the surgical discectomy.
Patient was having like after like before 10 months back here he diagnosed as diabetes, like 550 was his sugar, and after that he started having the symptoms, and the symptoms he was saying is along the L5 route.
I
So
told
I
you,
was thinking
it
whether
depends
like
on you can go ahead with the root block again, or you can think if you have to find out what is the culprit, whether it is a diabetes, whether it is a disc, or whether it is a muscle. They are the three common things. You have to first rule it out, that what is the possible, what is the culprit. If it is a diabetes, there is nothing to do. Then you have to rely on the medications. If it is disc, the choice is your ozone, choice is your surgery. If it is myofascial pain, then it is the 5% dextrose in the psoas muscle. So you have to think for the where is the pathology, and you have to target that.
okay, sir. Thanks.
One more case for discussion, sir. 50-year-old patient came with bilateral knee pain. It was severe 1 month before, and they had went to some other center. There they got it effusion. Effusion was there. It seemed about 30 ml of effusion was removed from one leg, which was more severe, and steroid was put. 1 month later, he came to me and I scanned him again. The same leg, almost moderate amount of effusion was recollected, but pain severity was less. On his X-ray, there was synovial calcification noted on the medial side, posterior aspects, and on bilateral knee. He had more pain in the left knee, less in the right, but X-ray of both knee joints were there was synovial calcification, and right knee there was I scanned, but I couldn't appreciate any synovial hypertrophy. Left knee I saw the synovial hypertrophy and the moderate amount of fluid was there. For this case, how can I proceed, sir?
A recurrent fluid accumulation is quite common. Many times you will be seeing some patients has been aspirated 5 times, 6 times, and every time he received some steroid after the aspiration, and again after a few months, patients has. So this is not uncommon cases. So you have to think that this is because of the synovial inflammations. And in your patient, already you told there is a calcification that which indicates that there is a
In
chronic
X-ray,
synovitis.
clearly small balls were seen
Yes, so
on
in this
both the knees.
situation, you have to think for the disease modifying drug. If it is only knee joint, then the sulfasalazine is the best choice. If it is other joints as well, like in these patients, you must be examining the sacroiliac joint as well. If the sacroiliac joint is also involved, then you have to think for the spondyloarthritis and spondylitis, and you have to give the tofacitinib. But if the patient is having only knee joint involvement, then you can go ahead with the sulfasalazine only. So don't aspirate repeatedly. You just as 1 or 2 times aspiration is okay. Otherwise, you have to think for the long-term management with the reduction of the synovial inflammation, and your this kind of drugs, oral medications can be helpful.
Yes, yes, means right knee also he had a clinic X-ray wise this thing was there, but
You
clinically there
start
was
sulfasalazine. You start sulfasalazine. If sulfasalazine is not effective, then next line will be your tofacitinib. The other things.
only
There are some papers
sulfasalazine.
that in these situations, adalimumab, intraarticular adalimumab also given and with the good results. But that is having less evidences. I will be suggesting you to go ahead with the sulfasalazine, which should get good results.
How long I should continue this to
It
see
is a
the
long life. This kind of inflammatory conditions, you have to tell the patient that you have to take a long life, sort of almost for the whole life.
Okay, sir. Any precaution while prescribing for a long
No,
sulfasalazine
nothing. You have
for
to just
allergy?
monitor the routine blood and the liver function test routinely every 3 months.
So does
Okay.
methotrexate has
Then
any role in this?
Methotrexate can also be given. Like today, we saw this one similar kind of patient today. The patient was telling that I am having allergy to the sulfur drugs. So what we did, instead of giving sulfasalazine, we have prescribed methotrexate to them. So either of that, but the sulfasalazine having the better evidences than your methotrexate. But either of that can be given.
okay, sir. Thank you, sir. Thank you so much.
Even there are some papers or intra-articular methotrexate has been given in these situations. But again, not evidenced.
Okay, sir. Thank you.
Sir, if any patient is showing symptomatic improvement for any chronic pain with duloxetine, pregabalin, and we are not planning for an intervention, then can we continue with these drugs for lifelong
Yes,
or?
these drugs are very safe. Normally, duloxetine can be continued very long time. Pregabalin can cause weight gain and some other effects. Try to switch to gabapentin from pregabalin if the patient needs long-term medications. Pregabalin should not be given for lifelong. Gabapentin is safer than the pregabalin in long run.
So in long run, gabapentin is safer.
Right.
Okay, and duloxetine can be combined.
Yes, gabapentin and duloxetine can be combined together for long term.
Okay, sir.
Okay, so if no more questions, good night for today.
Good night, sir. Thank you, sir.
Good night.